My guest today is Dr. Christy Kesslering. She is a radiation oncologist and a member of the Society of Metabolic Health Practitioners, which I'm a board member of as well. And you've also held many leadership roles through the years. You've been named a top doctor multiple times by Castle Connolly, Chicago Magazine, and but you spend now all of your time helping patients, real world patients with cancer and without cancer. And thank you so much for joining me today. But first, be sure to check out my new pamphlet. It's called 5 Things You Need to Know About Cancer and Metabolic Disease. See it in the link in the description below.
So I've been working in the cancer field for a long, long time, over a quarter of a century. But I have been incorporating metabolic health into my own practice for a number of years now, because we have seen so much in obesity-related cancers. And so it became an area of great interest to me. And I have slowly left my conventional practice to really work on metabolic health full time, because there's such a need, and patients don't typically get the support when they're in the conventional medical world. There's so much conflicting information. So what I thought that I would do tonight is just run through, again, I have a PowerPoint just because I like to use it as our launch, as our talking points, and to really give you some visuals as to why I'm saying what I'm saying. And then maybe we'll go over a little bit of why is that diet world so confusing when it comes to cancer. So hopefully everybody can see that. So we're going to talk about, again, nutrition and cancer. But as you can see from my nice, beautiful picture, we're going to talk a lot about how low-carb ketogenic diets play into this. So first, we hear all the time that cancer is a lifestyle disease, that really the genetics of cancer are such a small percentage of our actual cancer diagnoses, that about 90 to 95% likely are attributed to lifestyle factors. And the top 5 being some that we already know very well: smoking, alcohol use, sedentary behavior, being overweight or obese, and then of course just poor dietary choices. You know, if we're drinking a bunch of soda pop and processed foods, it's obviously not optimal for keeping cancers away. But there are also other things that are lifestyle related. We have environmental toxins, things that are coming in through our soils, our waters, circadian rhythm. You know, are we going to sleep at a regular time? Are we getting up at a regular time? Are we in front of screens 24/7 right up until bedtime and maybe into the wee hours of the night, etc. And just getting outdoors and being in the sunshine. We rarely do that anymore because we have such indoor life. So just a few things to think about. But what I want to touch on mostly is that metabolism, that diet, that obesity piece. So what we know is more and more cancers continue to be associated with obesity. So we can't say 100% that obesity causes these diseases, but there seems to be these patterns that we see. And obviously our most common cancers, breast cancer, prostate cancer, colorectal cancer being in there, but we're even starting to see some links into cancers that maybe we wouldn't expect as much, like even lung, although that's not on this list. But so really an interesting conglomeration of cancers from all different kind of walks, so to speak, not just our normally associated kind of hormonally driven cancers.
Right.
So when we think about obesity, and I think a lot of you guys are probably very aware of this insulin connection, IGF-1 or insulin-like growth factor. But when you look at this picture, you can see that obesity, there's a little double arrow in there. So obesity can drive elevations in these hormones, insulin, IGF-1, the leptin to adiponectin ratio. So maybe leptin resistance, low adiponectin, again, other hormones that are associated with obesity, and then other inflammatory cytokines and what's called VEGF. But if those are high, they drive obesity. If obesity is high, they drive those numbers. They're interconnected. They go both ways. And what we know is that this picture, these hormones, then can drive growth factor signaling, vascular changes, the microenvironment changes, systemic inflammation, and all of those things can cause increased cancer risk and cancer progression as well. So let's look at carbohydrate intake. So that's what we talk about a lot in the ketogenic or low carb world. But let's talk just about if people eat carbohydrates, eat sugar, what happens? So this was a study that looked at carbohydrates, but also at the glycemic index and glycemic load. You may or may not be familiar with those terms, but glycemic index is how quickly does it raise your sugar after you eat it? And then glycemic load is how much of that food are you eating? So a bite versus, a whole big, box of cookies. So what this study showed was that there was an increased risk in development of post-menopausal breast cancers. In the first panel, we're just looking at ER negative breast cancers. And in the second panel, we are looking at ER PR negative cancers. And you can see that the light blue bars are all set at 1, a hazards ratio of 1. And then that was for the lowest intake group. And then the darker blue bars are how much increase in risk was there in compared to that highest carbohydrate group. So highest carb versus lowest carb, highest glycemic index versus lowest, highest glycemic load versus lowest. And you can see that in fact, there are multiple or all of those steps are increased risk. But this is not enough risk to actually say that that causes the disease, because when we look at observational studies, this is where we get into the confusion place, is if there's an increased risk, this might get reported in the literature as high carbohydrates cause ER/PR negative breast cancer. But that's not what this is showing. It says there is an increased risk, but that hazards ratio doesn't reach 2 or more. It's only 1.6, 1.2, 1.4. So they're not high enough to say that that's the actual driver of the disease, but it does say that there is some association there. So when we look, at this next picture, this one is showing early onset colorectal cancer. So that by definition is a colorectal cancer less than age 50. This was a study done in women looking at the, I believe it was the big nursing study, the Women Nurses Health Study. And so this is looking at sugar sweetened beverages. So things like colas and juices and other sugary beverages. And what they found is that if the women averaged about fewer than 1 sugar sweetened beverages per week, right? So that's somebody who really doesn't drink sugary drinks versus somebody who drinks 2 or more every day, there was a dramatic difference, a 2.5 times increased risk of developing that colorectal cancer. And interestingly, they also found that for every additional serving per day in high school, so going way back, so if during their high school years, they admitted to drinking multiple or even just 1 a day, but every additional serving per day increased that risk by an additional 0.32 or an additional 32% increased risk. So you could see that that really is now starting to say, hey, maybe this is really driving the cancer, that if we actually drink sugar, that is bad for colon health. So let's actually look. So those were 2 studies looking at intake of glucose or intake of carbohydrate. And so now what I want to have us do is look at blood glucose levels, because most of us are pretty aware that when we eat sugars, high carbohydrate foods, we may eventually develop higher levels of blood sugar, right? That's pre-diabetes and diabetes. So our sugar levels at fasting might be higher. And what this shows is this is a lot of different cancers, all cancers, colorectal cancer, esophageal, liver, pancreatic. And you can see that as you're fasting, glucose goes from less than 90, slightly higher risks if we're in the 90 to 100, much higher risks as we are to 109, much higher as we get into that 110 to 125. If we're really high, right, fasting glucose is at 126 plus, or if we get into the 1 over 140s, we can see that, those risks continue to go up. Again, this was an observational study. These hazards ratios do not hit 2. But this was in a very, very large group of patients. So it is interesting and associated. And let's look at the next one. If we just pull out pancreatic cancer, this is actually looking at over 25 million patients, looking in their National Health System database and looking at fasting glucose and rates of cancer incidence in pancreas. But remember, pancreatic cancer is not very common compared to breast, colorectal, prostate, et cetera. But what you can see is that this was only a 5% incidence rate per year at low levels of sugar, but at high, so 126, that's 3 times as many. So that is pretty dramatic, 3 times. And then if they were actually on medication for their sugars, that actually got up to almost 4.5 times as many. So now we're starting to see, oh, guy, this maybe really is real. And from a pancreas standpoint, if we think about it, if our sugars are high, our pancreas is overworking 24/7, right? It is dumping insulin all the time. So that is a very interesting link, pancreatic cancer, glucose, and insulin. But we can look at glucose and carb intake or blood glucose, but I think all of us in this community realize it's really even before that. It is insulin, it's insulin resistance. And that is really where I think that the light starts to shine. So we know that based on the different macronutrients we eat, we may have different blood sugar spikes, time to elevations, length of elevation. But our foods are not individual macronutrients, right? Everything is a combination of carbohydrate and protein, or protein and fat, or all 3, depending on what we're eating. And what is very interesting, and as we all know, that we all have different glycemic responses to the same foods. This was a study that looked at non-diabetics. So we weren't anticipating differences, right? They all had relatively, in theory, nice low fasting glucoses. But if you actually look here, there's probably a pretty good spread. Having 120-ish fasting glucose is probably a little high for a non-diabetic. But you can see that the higher that fasting glucose, maybe the higher the response to this meal. And this, I believe this meal is a relatively high carbohydrate, think it was a sandwich or something. I can't remember exactly, but you can see how there is a difference in people's response, how quickly that glucose comes up and how quickly it goes down. And so we kind of see this general play out that when somebody is diabetic, a small carbohydrate load can cause dramatic elevations in glucose that may stay up for many, many hours. But when we're in the pre-diabetic, or even maybe before that, where our insulin levels are starting to, go up a little bit more, but by fasting, they're still back to normal and our glucoses still look normal, we do still have a more dramatic rise to glucose. And so if I put a continuous glucose monitor on somebody, I might see where that glucose is actually bumping after really a relatively small amount of carbohydrate. And I will tell you, just for an example, I had a patient wearing one, and I can't remember if I had her wearing one or if she was doing her blood glucose with a finger stick. And what she found is that she ate one piece of quote unquote keto bread and her sugar went to 177. So don't believe labels, trust your own body, and know that different foods and different combinations are going to affect everybody differently. And that's why I come from the camp of, we should really be testing in certain situations. So I know that a lot of times we just want to keep it simple. And if we're doing this just for general health, changing our way of eating and making sure that we're losing weight and feeling great, that's awesome. But sometimes I will have people thinking they're doing everything right, but their insulin isn't really coming down. So I always like to get testing before and after making changes and see where things are going. Or when people are stuck, it gives me a lot more information to know where all these markers are, so that we're kind of using that, test and don't guess method. Some of you may be aware, and I'm sorry that this color didn't come out great. Hopefully you can see that there are 5 lines on here, but these are the Kraft curves. So some of you may be familiar with Dr. Kraft, and he was much more interested in that insulin response, not in the glucose response. And so he gave a dose of carbohydrate, of glucose. And then what he found was that there were still a wide variety of insulin responses. So the top line, that gray line, is likely an undiagnosed diabetics, because these were supposed to be normal fasting sugar patients. But that patient had a significantly elevated insulin, but that insulin could have been keeping his sugar looking normal. It just needed more and more and more to do that. So really that high insulin is an undiagnosed diabetic. But then the next two, kind of the dark gray and the dark blue, are overproductions of insulin. So when insulin gets overproduced, right, then it's constantly on and it's constantly pushing sugar down, which often then makes us hungry again at that 2 or 3 hour point. And then we need to eat again because our sugar is going to drop too low because our insulin is still high. So the only way to really fix that is by changing the foods that we are eating so that we are not getting that dramatic insulin response. So now let's think about that more from a cancer perspective. So when we start looking at insulin and cancer risk, so this is a study that looked at prostate cancer. And now we're starting to get into those much bigger hazards ratios. So here, these are insulin levels, so actually even still higher than I want to see typically, but this was looking at a fasting insulin. If you had one less than 6.4 compared to an insulin of 8.8, so I didn't put some intervening groups, but just to show you the lowest to the highest, you can see that in this group of patients, there was a 2.5 to 3 times the risk of developing a prostate cancer just because your insulin was 2 points higher. And I will tell you that the average American probably is 9, 10. So all of our average Americans are already in this highest risk group. So then interestingly, this group then also looked at waist to height ratio. So you can think about waist being belly fat, visceral fat, right? So the apple shape. So if somebody also had a high waist height or waist to height ratio and a high insulin, they were over 8 times as likely to develop a prostate cancer than if they had a lower insulin and a lower waist to height ratio. So that's pretty dramatic. That is saying that insulin very likely is driving that disease process. And we know that insulin also tends to drive that waist to height ratio. When we look at a breast cancer population, this was a study, again, just observational, looking at post-menopausal breast cancer, but they found again that a very low fasting insulin, so this one they used 3.6, they had, let's see, if you were greater than 9.5, you had a 2.5-fold increased risk of developing a breast cancer. And it was graded, meaning that the more insulin, the more likely you were to get a cancer. And why do I want to pull it back away from obesity? This was a nice study that looked at weight. So either you were overweight / obese, or you had normal weight. But then they took it a step farther, and the right panels of each of those are the insulin. So you can see that with low insulin versus high insulin, overweight people were twice as likely to get a breast cancer, and normal weight people were twice as likely to get a breast cancer. So it wasn't about weight, it was about insulin. And then HOMA-IR, which is an insulin resistance score, it uses a combination of glucose and insulin to test that insulin signaling sensitivity. And both of those were elevated in both groups similarly, but they did not hit that doubling of hazard ratio. So those were both around 1.7, 1.8. And then there's another hormone that I mentioned, IGF-1, or insulin-like growth factor 1. So again, it's a sister hormone to insulin. It has been associated with growth of cancers. It is in the, we hear a lot about mTOR as a growth pathway, but IGF-1 can turn on that mTOR growth pathway. And so we hear a lot about it, and that we should try to lower IGF-1, just like we should try to lower insulin. And this is a nice study that showed that with increasing risk or increasing levels of IGF-1, it dramatically increased prostate cancer in men. So 4 to 4.5 times more likely to develop prostate cancer with a high IGF-1 versus if you were in the lowest risk group. And interestingly, when they looked at men older than age 60, it actually almost doubled that risk. There was an almost 8-fold increased risk in men who were over the age of 60 in the highest IGF-1 group. And when we look and we pull in the PSA, because that's kind of what the conventional world looks at as PSA. Well, interestingly, if you had a high PSA and a low IGF-1, you were actually less likely to develop a prostate cancer than if you had a high IGF-1 and a low PSA. But you can see on the right, those are all PSAs over 4, and how they really are much higher than those who have low PSA. So that combination of having an elevated PSA with an elevated IGF-1 is much more powerful of a risk predictor. So in theory, if somebody had a rising PSA, maybe we should be checking IGF-1. It makes sense. We don't have that data yet. And what has also been shown is if you are diagnosed with a cancer, and then this particular next 2 slides are breast cancer, is that if you have elevated insulin, you tend to have elevated risk disease or disease status, meaning in the first group is tumor size. So tumor size less than 2 centimeters, less likely if you had high insulin. Whereas, so if you have high insulin, you are more likely to have a bigger tumor. You are more likely to be diagnosed with node positive disease. And if we're just looking at stage, you can see how the stage that goes along with bigger tumor size, more nodes involved, etc. So as insulin goes up, so does the risk for a higher stage disease. So diets, can we do something? Well, I hope I just told you the story that high levels of insulin and IGF-1 do appear to be direct causes of the obesity-linked obesity-linked cancers, because they have very high, or at least meet a hazards ratio of 2. But we've seen even 4s, 8s, pluses. So we know that there seems to be this direct cause. Again, these are observational. So it makes sense that if insulin and IGF-1 appear to be driving this cancer link, regardless of weight, because we saw that with the BMI study, or the overweight to normal weight. Well, it makes sense that if we all follow diets that will help lower insulin and IGF-1, then we should lower the risk of developing a cancer. But why is there so much conflicting advice then about diet and cancer? And we should be following a low-fat diet and a Mediterranean diet and a plant-based diet and a ketogenic diet. But why? Well, as I believe everybody would would realize is that any diet is first and foremost going to get rid of the processed foods. We're going to get rid of pizzas and ice cream and cakes and donuts. And those are the fat carb combinations that are very insulinogenic. So when we combine fat and carbs, we really drive insulin and IGF-1. So step one is getting rid of that. But let's look at some comparisons. So when we are looking at a very low carb ketogenic diet versus a low fat diet, you can see that all of those, or both of those diets, do help lower insulin, help lower leptin, which I mentioned up front, lowers HOMA-IR, lowers even the triglycerides and the triglyceride HDL ratio, which is a surrogate for insulin resistance. It lowers abdominal fat, which is, an insulin resistant type of fat. But you can see that the blue bars, our ketogenic diet, always seems to do it much, much better and in more patients. So when we start to pull out patients with varying levels of metabolism, Dr. Volek has been so wonderful in this arena and giving us so much information. But when he looked at metabolically, patients with metabolic syndrome, he found that it was really only that low carbohydrate diet that reversed the metabolic syndrome. So it is very interesting to see that and to know that a lot of cancer patients are in that, even though they may not meet the full criteria for metabolic syndrome, obviously have some degree of metabolic dysfunction because of this glucose and insulin signaling piece. And when we look at a Mediterranean diet, which is the American Cancer Society diet, compared to a ketogenic diet, this was actually done in cancer patients, we see, again, some lowering of glucose and insulin and IGF-1 in both diets, but you can see how the ketogenic diet does that much, much better. And when they actually surveyed the patients who were following the ketogenic diet felt like their cravings were much better controlled in comparison to those on the other diet. And then just to throw out a couple of, because we always hear, but you shouldn't do a ketogenic diet because meat causes cancer and fat causes cancer and dairy causes cancer. And I want you to all think about my initial comments about epidemiologic data and hazards ratio, because pretty much most of these things that we get scared off on are usually observational data that don't control for all of the known factors. So as we have learned from kind of the ketogenic space, that most meat eaters eat a high carbohydrate diet. And that may be why meat is associated with cancer. But I always say, come on, if you go to McDonald's and you look at a value meal, you're going to tell me that the one thing in there that is driving disease is the meat, which is probably the only real food in that whole thing, so we have to look at everything with a grain of salt, and any of the data or the studies that have really dug into meat, inflammation, growth factors in the setting of a ketogenic diet, it does not turn those things on. We have seen even in the carnivore space that we can reverse insulin resistance and diabetes, putting people on 100%, high fat meat diets. And fat is, again, similar things. And the fats really that are the problem are these processed fats, these seed oils, our old fashioned Crisco's and Westman oils and, all of those things that actually did create quite a bit. There's a lot of data on linoleic acid, omega-6 fats driving cancer in randomized trial, putting them on saturated fats versus polyunsaturated fats. And usually those polyunsaturated fats actually drove cancer. So there is some laboratory data in that. And then there's also some observational data that those eating kind of fried foods and things like that. But we would say people who are eating fried foods really are not looking at their diet in any way, shape, or form. And again, dairy, milk in and of itself is a high carb, high fat food, right? That can drive insulin and IGF-1. But if we're doing dairy fats like butter and ghee and maybe some cheeses, is that really leading to cancers? And I would say no. But that, again, is my bias. And I do think there are some people where dairy is inflammatory or where certain things, we all come from different genetic makeups, different heritages where our natural foods may all be just a little bit different. But if we are testing, if we know where our insulin started and then we're making changes and then we see where our insulin ends up, we know if we're doing things in the proper manner for us. And so again, I usually recommend doing some lab work and knowing where we are and what is moving in the right direction, because sometimes we feel great, but maybe things aren't exactly how we think they are. And I can sometimes see things a little bit earlier when I'm looking under the hood, so to speak.
If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.